Hello, everyone, and welcome to today's live broadcast, Integration of the Simplexa C difficile direct assay into a two-step algorithm for the laboratory diagnosis of C. difficile, presented by our keynote presenter, James Snyder, PhD, Professor of Pathology and Laboratory Medicine, University of Louisville. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want, anytime you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. Professor Snyder will be following up with your questions via email. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the slide window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use the Q&A button to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits and will be available for on-demand viewing through February of 2018. Please click on the button in the bottom left corner and follow the process to obtain your credits. Now, please join me in welcoming Professor James Snyder. I will now turn the presentation over to him.
Thank you. It's an honor to be able to spend some time with you during this webinar or keynote address. And I'd like to thank LabRoots as well as DSOR and Molecular for sponsoring this keynote address. I hope by the end of this presentation you'll have an appreciation of the serious nature and the challenge that we are facing with regards to both the laboratory as well as the clinical diagnosis of Clostridium difficile infection. I'm going to be speaking actually in two parts. Number one, give you an overview of C. difficile disease and focus secondly on the laboratory aspects where we have evaluated a relatively new molecular technology known as the DSOR and XL Liaison C. diff PCR, formerly known as the Simplexa system. And we're going to be talking about how we have evaluated it and how it fits into our algorithmic approach to the laboratory diagnosis of CDI. This is a photo of the University of Louisville Hospital, where the hospital itself is the primary teaching institution for the University of Louisville Medical School. The hospital is primarily known for trauma and essentially is a trauma-driven hospital. But in essence, it is basically analogous to what we normally refer to as the city-county hospital. We also have a bone marrow transplant center located in the hospital as well as in the cancer center adjacent to the main facility here. I should also mention the fact that we recently consolidated two laboratories, the University of Louisville laboratory, in which I direct the microbiology and the molecular diagnostics program, and merged the laboratory with another local hospital, resulting in the volume of specimen testing nearly tripling. We are in about our 10th month of this consolidation, and as you can appreciate, integrating personnel from two different institutions, medical staffs, and etc. It's not an easy task, but it's a challenging, and really I have to be honest with you, it was a fun task to interact with so many people and bring forward a program of rapid response, rapid diagnostics, and improved quality of especially laboratory testing, which we hope will translate into better patient care and savings to the institution. The objectives for our keynote address today are listed there for you, and I'll give you a little overview of the epidemiology and the incidence of this serious infection. We'll summarize some of the assays that are available in both conventional as well as molecular. Go over our study evaluation design, share with you our results, and conclude with comments related to the performance of the technology and related applications to patient management. In terms of epidemiology, as everyone knows, or should know, C. difficile accounts for a predominant number or is the leading cause of infectious diarrhea in the U.S. healthcare environment. It accounts for approximately 15 to 25% of infectious diarrhea. Approximately 453,000 individuals are affected each year, with a mortality of approximately 29,000 deaths in terms of the current statistics. And it's also important to look at the financial impact. From the cases alone, it's been estimated that one case costs approximately $9,000 to $13,000. The infection is caused by a bacterium known as Clostridium difficile. Clostridium difficile is a member of the Clostridium genera, and Clostridium difficile is a gram-positive, spore-forming rod, and it's an anaerobe. The organism is associated or has two strains. There's a toxigenic strain and a non-toxigenic strain. So these toxigenic and non-toxigenic strains can be found in the host, where they survive in the colon. The toxigenic strain is the most important one of the two in that it produces toxins. And the three toxins that are produced by the toxigenic strains include toxin A, toxin B, and occasionally there are strains that will produce the binary toxin, sometimes referred to as NAP1, O27, and BI. Toxin B is the most prominent toxin of the three and accounts for the infectious process. In other words, toxin B is responsible for the associated diarrhea following the activation of toxigenic Clostridium difficile. Obviously, as you can appreciate and probably have even read in the papers, C. difficile has markedly increased in most countries throughout the world. So it is a worldwide challenge. In the U.S. alone, estimated costs have been between $500 million and $1.5 billion spent alone on C. difficile infections, and is a major burden to the hospital environment and to the institution in general. When it comes to laboratory diagnosis, and I want to make it very clear, there is a difference between laboratory diagnosis and clinical diagnosis. The laboratory diagnosis is independent of the clinical diagnosis. We're going to be focusing on the laboratory diagnosis. And when you hear terms sensitivity and specificity, from the laboratory perspective, we're evaluating the analytical sensitivity, specificity, and etc., which does not relate to the clinical sensitivity and specificity. I think it would be a good idea if we consider reviewing the differences between clinical and analytical metrics such as sensitivity, specificity, predictive value, and etc. So when we come to the point of laboratory diagnosis, we have a couple options available to us in the form of conventional methods or molecular. And of course, molecular technology is becoming widely used in the laboratory diagnosis of a variety of infectious diseases. When we focus on conventional methods, the two methods that have been used for years are the toxigenic culture and the cell culture cytotoxicity, sometimes referred to as the cell culture cytotoxicity neutralization assay. The toxigenic culture is designed to recover the organism Clostridium difficile. Once the organism is recovered in culture, then that isolate is tested for its ability to produce toxin. The cell cytotoxicity, or C, or the cell culture cytotoxicity, the cell culture cytotoxicity neutralization assay is used to detect the toxin. Once again, remember, the toxin is the primary virulence factor. Both the toxigenic culture and the cytotoxicity assay are regarded as gold standards when evaluating technologies designed to detect Clostridium difficile. Additional conventional methods which have become very prominent in the laboratory today are the enzyme immunoassay tests, beginning with the glutamate dehydrogenase test. This is an antigen that is carried by both the toxigenic and the non-toxigenic strains. Thus, the GDH assay does not differentiate between toxigenic and non-toxigenic strains. Then we have the enzyme immunoassay designed to detect toxin. Once again, primarily toxin B. Toxin A may be there, but it's toxin B that is the most responsible virulence factor in causing the disease. Toxin A is essentially a secretory toxin which essentially allows the entry of toxin B into the mucosal lining and can promote then the activity of toxin B in producing active infectious diarrhea. Then we have molecular methods, sometimes referred to as NAT, nucleic acid amplification tests. Two of the most prominent NAT tests are the loop-mediated isothermal amplification, and the other being, and most prominently used, is the PCR nucleic acid amplification. Both systems are molecular in nature and are capable of detecting toxigenic Clostridium difficile. And I think one thing we need to remember is when we're talking about these molecular methods, they detect the gene. They cannot differentiate between toxigenic or toxin-producing organisms, but detect a gene that code for the production of toxin. Whether or not that gene is active or actively coding for the production of toxin depends upon the use of a toxin detection assay, such as an enzyme immunoassay for toxin A and B. But molecular methods are very popular today, and there are two schools of thought regarding the laboratory testing for C. difficile. One school of thought is the use of PCR for direct testing, no other test needed. The second school of thought is an algorithmic approach, and we have elected to go with the algorithmic approach, which I will present to you in a moment. With regards to our study design, and I remind you this was an evaluation, this was not an in-depth, high-volume sample study. It was designed to determine or ask the question, can the Diasorin PCR instrument or technology perform at a level comparable to other PCRs and be integrated successfully into an algorithmic testing format. So in our study, the first criteria was the sample being a stool, but specifically it must be a liquid stool. A stool that conforms to the shape of the vessel in which it's been placed, or conforms to the shape of the vessel. And they involved all hospitalized adults. The specimens were tested prospectively within 24 hours. They were not delayed beyond 24 hours, and they were stored at 4 degrees. In our laboratory, we use an algorithmic approach for the detection of the C. difficile, and you can call it a 2-step, 3-step, depending on the circumstances. The 2-step is essentially involving an enzyme immunoassay, which is packaged as a kit, involving glutamate dehydrogenase, testing for the antigen, and the toxin A and B. In our laboratory, doing the GDH and the toxin, if both are positive, we do not do confirmatory testing. It is a final result. If the glutamate dehydrogenase is positive and the toxin is negative, that flexes to confirmation using a PCR. So the PCRs that are used in this evaluation primarily are for confirmation, but to enhance the value of the study, we did PCR on every specimen, irregardless of the glutamate dehydrogenase toxin results. Once again, GDH, if it happens to be negative and the toxin was positive, we would confirm with PCR. If both the GDH and the toxin are negative, no additional testing was done. So in our evaluation, 3 molecular assays were involved. The first, as you can see, Great Basin, was the technology that we had been using in our laboratory for 4 or 5 years. And so it's our in-house method, and it was used for confirmatory testing only. We also included in the evaluation the Expert Infinity from the Cepheid folks, and the primary focus was on the Diasorin assay, the C. difficile direct assay from Diasorin Molecular. So our goal was to basically ask the question, does the C. difficile direct assay fit very well into an algorithmic testing format in a laboratory? I remind you again that all specimens were tested directly with PCR, the exception being with our Great Basin. So we continued in our standard format with our GDH, toxin, and if necessary confirm with the Great Basin, but all the specimens were tested directly with both the Expert Infinity and the Diasorin apparatus. What you're looking at is the Diasorin instrument known as the Liaison MDX. And the system is very conveniently, from a space point of view, accommodated in a laboratory. You'll notice there is a disk, and that is the focus of the testing platform in the system. And the next slide will show you how this assay is prepared and placed on the disk for detection in the instrument itself. So you simply take the stool sample, you dip a swab into that sample, and remove any excess stool by pressing the swab against the inside of the container. And then you swirl that swab in a sample prep solution known as a buffer and deposit or discard the swab, followed by scanning the Simplexa reaction mix or master mix, and also scan the amplification disk and the patient ID. This goes into the computer-assisted database and is a very slick system. The second step is to pipette the specimen. Once you lift the foil from the well, you pipette the direct reaction mix into the designated R well, as it says there, and then pipette the diluted patient sample into the sample well. The disc is resealed with foil, and we tear off the perforated edge and place the disc in the device or platform and close the lid, and within about an hour you will have your results printed out electronically, and simply you can click save and then click the run. So as a result of that, it's about an hour and 15-minute test time. It's user-friendly, minimal hands-on time, which is important from a labor perspective. Once again, this is our algorithmic approach, and just to review that for us, we're looking at the laboratory diagnosis of C. difficile using a two-step method involving glutamate dehydrogenase and toxin detection. So you can see the various results across the top, beginning with a positive GDH and a toxin positive. The report would go out that Clostridium difficile infection is likely. If we have a negative GDH but a toxin positive test, that would indicate CDI is likely. Or we would also flex to confirm with PCR. If we have a positive GDH and a negative toxin, that also is flexed for confirmatory testing using PCR. And if the GDH is negative and the toxin is negative, we report that CDI is unlikely. So from the PCR perspective, we either detect or we don't detect the gene. And once again, it's important to note that the PCR does not detect toxin and cannot differentiate between active disease and or a carrier or colonization state of the patient. Very important aspect to remember if doing direct PCR. I should also mention there are studies coming out that indicate how better to utilize PCR as a direct assay, and that's for another lecture, but at this time let's look at our data. As I indicated in the beginning, we did not have a huge sample size by statistical purposes. A total of 196 specimens were eligible for testing in the evaluation, and you can see the breakdown of the results beginning with glutamate dehydrogenase positive, toxin positive. There were a total of 11. Now, because the Great Basin was used as only a confirmatory test under our normal conditions, it was not tested under that circumstance. However, noting that the stools were also tested directly between the diasorin, formerly Simplexa, and the Cepheid Infinity, you can see of the 11 that were detected, the diasorin detected all 11 positives, as well as the Infinity. Very good correlation there. Those that were GDH positive and toxin negative, there were 25. As you can see, of those 25, 15 in confirmatory testing by Great Basin were regarded as positive, 10 were negative, versus the Simplexa or the diasorin, which 15 and 10 respectively. So the comparator, or the index test in this case, the Great Basin, the integrated cycler diasorin, agreed 100%. The Infinity picked up one additional positive. So is this a false positive or a true positive? Well, to answer that question, we would have had to have done either a toxigenic culture or a cell cytotoxicity neutralization assay, which we did not do. And 9 of those were negative. So the question is, was that positive a true positive or a false positive? Those that were completely negative for both GDH and toxin, once again, you would not test those with your index test, in this case the Great Basin. But the Diasorin picked up 2 additional positives versus 157 that were negative. The Infinity picked up 3 additional positives with 156 being negative. So the question once again is, are these true positives or false positives? And doing either toxigenic culture and or toxin analysis with the cell cytotoxicity neutralization assay would have answered that question. We did encounter one situation where the GDH was negative but the toxin was positive. And once again, with the Great Basin, the result was positive. And for the Simplexa as well as for the Infinity, they respectively detected as positive that which was toxin positive by our 2-step algorithm. So once again, there's pretty good correlations you can see there. To kind of break down the data in its entirety in terms of specifically the agreement of the Diasorin Simplexa, probably should update my slides, versus the Cepheid Infinity. Overall, there were 28 positives, 2 negatives. There were 1 negative and 1 positive by Infinity, 164 were negative. And once again, there were 29 positives versus 166, which adds up to the total number of tested. The point here is that overall the percent agreement was very, very good. Now, we did not do statistical analysis in regards to sensitivity, specificity, predicted value, and what we were looking at was accuracy and the positive percent agreement, the negative percent agreement, and overall. As you can see, there was very good correlation between the respective molecular instruments, and the data is very, very good. So with regards to current guidelines, a lot of people have been asking about where are guidelines available today to assist laboratories and clinicians with regards to diagnosing accurately Clostridium difficile infection. Well, the current guidelines are those of the European guidelines that you can see listed there. These guidelines are a couple years old or nearly 2 years old, but are available on the web as well as in the reference that is cited there for you. The European guidelines advocate a 2-step or 3-step approach, with PCR being used either in the 2-step or as a confirmatory testing. In other words, if you do PCR and as part of the 2-step, some laboratories will do the PCR first, and if the PCR is positive, then they will flex to toxin assay, usually an enzyme immunoassay. So it can be used in that format, or it can be used as a confirmatory test following the 2-step algorithm involving the antigen and the toxin EIAs. Once again, the European guidelines endorse that either way. I should mention that the American Society for Microbiology is in the final stages of actually writing an evidence-based guideline on C. difficile testing. The focus is primarily on diagnostic accuracy of the algorithmic approach versus or along with the direct PCR. We anticipate that publication to be in print by early to mid-spring. And I can tell you without any reservations, we're going to finalize the document in the next few days and submit it for publication. The IDSA is revising their current guidelines. The one that you see listed there doesn't go a lot into laboratory assays. It's more patient management, infection control, and etc. So as a result of that, the new updated version, I'm not sure when that will be due, but the IDSA is revising their guidelines. So before we summarize what we've been talking about today, I'd like to go over for a few moments the advantages and limitations, or strengths and weaknesses of the current Clostridium testing methods. And I'll start with the nucleic acid test. Nucleic acid tests have a very high sensitivity, and as a result of the high sensitivity, it overcalls or increases the rates of C. difficile disease. Once again, remember that the molecular assays cannot differentiate between colonization and active CDI. So if you're doing direct PCR, and the high sensitivity associated with that technology has a tendency to overcall and inflate the rates of Clostridium difficile infection. That is very, very important from the perspective of reimbursement. Basically, most of you, or maybe all of you, are familiar with the CMS guidelines known as value-based purchasing, and are penalizing institutions that have excessive CDI rates. And by virtue of the penalties, they are losing reimbursement and are losing a lot of dollars, if you will. So that has to be considered one of the considerations as to whether or not we should be doing direct PCR. I'm not going to answer that question today, but once again, something to consider as members of different institutions. It affects infection control. It also affects antibiotic utilization, all of which adds up to cost. But there are some positives to direct PCR as well. And before I get to those, keep in mind, molecular tests are expensive. They are not cheap. So we have to take that into consideration with regards to how we approach our C. difficile testing. To remind you once again, the molecular technologies, in this case, detect the gene that codes for the toxin but does not detect the toxin itself, and thus, once again, cannot differentiate colonization from active disease. Overall, the molecular assays for C. diff, like any molecular assay, lack clinical specificity. And when you have this deficiency in clinical specificity, it inflates your CDI rates and the consequences that I just mentioned with regards to reimbursement and excessive cost to the institution. On the positive side, if you will, in addition to being highly sensitive, molecular assays used for C. difficile testing may promote better infection control measures. It may promote better utilization of antibiotics, for example, withholding antibiotics if the test is negative, and it will have a positive influence on antimicrobial stewardship programs in general. If we look at the advantages and the limitations of our more conventional EIAs, GDH and EIA in this case, I think it's important to realize that glutamate dehydrogenase is modestly or somewhat less sensitive than your nucleic acid test and your toxin assays. Less sensitive for a variety of reasons, in that for a positive test you need a certain organism load, and if there are very few organisms in that specimen, it may be below the sensitivity of the assay itself. It's been estimated that GDH will probably miss, or likely miss, 20% of cases because of the low level of inoculum or low quantity of organisms that are in the specimen. That would indicate that the sensitivity of the assay would account for that, but this has been found to be somewhat common in patients designated as carriers. They have such a low organism load that the GDH may miss those because of the lower sensitivity that is associated with it. On the other hand, toxin tests are less sensitive but much more specific. So if toxin is present, it's been correlated with the fact that the patient has a more active disease, a more challenging prognosis, and would probably account for additional days in the hospital. So great specificity, less sensitive. They are rapid, and of course they are less expensive. Once again, the financial impact of which the laboratory has to be accounted for in terms of its overall expenses. So as I said, the GDH misses approximately 20% of the positives that are actually detected by the nucleic acid test, even in patients with symptomatic CDI. But a negative test, reminds you, does not rule out Clostridium difficile infection. So our recommendation is algorithmic testing involving the two-step GDH, enzyme immunoassay, and using molecular testing or NAT as a confirmatory in those cases where the EIA is negative. We find it to be very helpful. We have noticed that by doing this we have reduced our overall rates of CDI, and to even further improve our testing and relationship to patient management, we created a checklist that the physician and or nurse must complete that list criteria for eligibility of that stool specimen to be tested in the laboratory. And that checklist is sent to the laboratory and reviewed once again by the testing technologist, and to ensure that it meets the eligibility for testing. Some of the clinical criteria, and I think it's very important to remind everyone, there has yet to be developed a formal clinical and laboratory definition of Clostridium difficile infection, that is true infection. It does not exist. So from the clinical criteria today, we utilize such criteria as greater than 3 stools, liquid stools per day. If a patient's been on a laxative for the last 48 hours, the test is not performed. The specimen is not eligible. Have they had an antibiotic history of the last 2 weeks? And criteria like that are currently acceptable, but certainly we are in need of a defined, more formal definition of the clinical aspects of the infection as well as the laboratory definition. So by way of summary, the respective systems that were evaluated, with the primary focus being on the DiaSorin system, there was complete agreement between the DiaSorin and the gene expert with our in-house 2-step, 3-step algorithm. There was overall agreement of greater than 98% between the expert system and the Simplexa itself. Excellent data. And overall, we think that the DiaSorin system or technology would integrate very well with an algorithmic testing format such as the one that we use in our laboratory. So overall, it's a reliable method. We would use it as a confirmatory test only. And once again, the algorithmic testing strategy is what we follow. But once again, the jury is still out regarding the use of direct PCR or the algorithmic approach. Hopefully in some publications that will be coming out in the next year that will add clarification to the situation that we're currently dealing with. And I can honestly say that physicians are really challenged when they get a positive PCR result back. Challenged from the perspective of, do I treat it, do I not treat it, and what does this all mean? So we in the laboratory have to be available to work with the clinicians in addition to our infectious disease personnel, as well as support our infection control and prevention program, as well as the antimicrobial stewardship. So we play a great role in all those areas, but once again, we're still not there yet with regards to what is and what does not constitute true C. difficile infection. I would currently discourage standalone tests. I would not do a GDH alone. I would not do a toxin alone, nor would I do a molecular assay alone. Obviously, as we've been talking about, we recommend algorithmic testing, the two-stage involving the two assays that are listed there for you, and either the GDH or the nucleic acid test, followed by a toxin if you happen to get a positive GDH or a positive molecular assay. We alluded to that earlier, but once again, the recommendation or the preference is algorithmic test. So I'd like to acknowledge Ms. Thompson, Gina Thompson. She is our research technologist. She is responsible for the actual conduct of this evaluation and deserves a lot of recognition for completion of this evaluation. And obviously DSOR Molecular, they supplied the platform, the reagents, and I will also disclose that an honorarium was provided for presentation of the data. Thank you, and would be happy to answer any questions.